you said Jugalbandi, Sundar had only one doubt. Should we dance and come on stage? I think we'll let you all dance and have fun. Right, what we'll try to do over the next about 20 to 30 minutes is, instead of a regular talk, this is going to be more of a discussion on heart failure. We'll try to keep a discussion, and Sundar's suggestion was, as and when you want, you can break us. It's not going to be a continuous dialogue discussion by us. All of you are welcome to join into the discussion. Yep.
Yeah, good morning, everyone. At the outset, thanks for this forum. And a small remembrance about the great man, Professor Sam G.P. Moses, because he was the one who initially sowed the seeds for cardiodiabetology 40 years ago. And he was the one who started the unison between cardiology and diabetology, and in fact coined the term cardiodiabetology as well as so-called cardiomyopathy in diabetes. So I would like to remember him on this special occasion. And always forum in a diabetic conference on cardiology and vis-a-vis cardiology conference wherein diabetes talk comes, it's always met with a lot of interest. So without much ado, we will just start on a case. That's how we discuss this. So see, this is a routine case which we see. This is obviously a case. When we suggest a case, it is never a pure case, because we are not talking about theory. Obviously the patients are managed in the real world situation. We may not start a diabetes patient with a SGLT, we may not start the patients with a metformin, we may not start patients with a GLP analog. Whatever you see in a podium, in a theoretical meeting, will never happen in the real world. So this is what happens in most of the time. It's a 60-year-old garden variety patient, 10 years diabetes and hypertension 5 years, fine, asymptomatic for almost till 2 months ago, progressive dyspnea since 2 months, no angina, PND since 10 days, dyspnea at rest for 5 days. All these things were treated as lower respiratory infection. I'm sure almost everyone, every cardiologist and most of the physicians who deal with emergencies would see this, that no, 2 months sir, I have been having cough and cold, chali irumal na chonnanga. Nobody thinks of heart failure, because above the age of say 50, especially in a diabetic, any new onset dyspnea should never be, what do you say, poo-pooed as respiratory problem. You should invoke cardiac failure also into most of these patients. Otherwise, most of them get diagnosed so late. It's almost 2 months since he started having the symptoms, and the patient comes to anybody's clinic. It could be yours, it could be mine, it could be Sir's. Heart rate of 120. So that is the first important indication that your heart is under strain. Tachycardia. Blood pressure borderline 110/80. Afebrile, mild dyspnea at rest. JVP, of course. I mean, these are all undergraduate teaching. Of course, you can see if you want. And most importantly, look for a gallop sound. So if you have a gallop sound with a tachycardia, you are invariably treating a heart failure. And bilateral basal crackles. So this is how uniformly the patient comes. Nobody comes to the textbook. Nobody comes with a heart failure suddenly in the middle of the night. All those things may be 20% of heart failure. Most of the heart failure patients, I would request Dr. Prabhakar also to confirm on this, that most of them, they just walk in, ambulant heart failure, progressively deteriorating with PNDs in the night. And if you leave them without treatment, they may sink the next day. So this is how our patient comes. The drug list, as I told you, no fancy drugs, no evidence-based medicine. This is what happens in real world. I'm not talking about podium talk. This is sulfonylurea, metformin, calcium channel blocker, vitamins. This is how all our patients, most of our patients in real life are managed. There's no SGLT, no GLP and all. So this is how it's a garden variety. So investigations, what will you do? Investigations.
So basically first I will wear the cap of a physician or a diabetologist here. So when a patient like this walks into my clinic, as a physician, what will you do? The first thought, diabetic, probably mild fever, breathlessness. You do suspect a respiratory tract infection, which is much more common. That's what you do. But you don't wait for so long. The moment you realize that he is not all right, and one important thing is it's progressive. 2 months ago he was walking 5 kilometers, that's a warning sign. I think that is what all of you should remember. When to start suspecting a cardiac cause. I think that is very important as a physician. So at this stage, so far you have come here, apparently diagnosis is already there. He's given all the symptoms, everything is there. Now if you're going to do as a physician, what else can you do? That's the question. The most important thing that a physician can do, not depending on a cardiologist, one of the biggest fears any physician has is losing a patient, which is true. Come on, let's all accept it. All of us believe that if I send it to some fellow, he's not going to come back to me. So what will you do? You can do a simple NTproBNP for these patients. As an outpatient, NTproBNP is available as point of care kits. 10 to 15 minutes you can get a report. Even if you do the test, you will get the report within about a day. You don't have to wait for 2 months for this. I think should be the care. So how do you interpret NTproBNP in a patient in a chronic outpatient setting? Very simple. 125 is the cutoff. If it is less than 125, don't bother. Your patient does not have a cardiac cause. Beyond 125, the importance is looking at the age. Age less than 50 years, 125 plus is abnormal. 50 to 75, 250, double the value. If the age is more than 75, it's going to be 500. 125, 250, 500 in the outpatient setting in a patient presenting with breathlessness. If you had done it, you would have seen about 1,000 or 2,000 NTproBNP. Straight away, you need not have wasted the patient's time. That would have been an excellent test for this. Rest of the investigations, I think, are all routine.
I think point of care NTproBNPs are also available. And see, at least it will give you a rough idea. So it is like a quantitative troponin and a card test. At least something is better than nothing. So you should do a NTproBNP on all patients who present with dyspnea. New onset dyspnea, NTproBNP is the way to go. And I would not go into detail about others. Of course, echo is very important. Of course, always have a cardiologist as your friend. We are all there to help you. You can refer
Dr.
to us.
Parnavan sir wants to say something. Yeah, go ahead, sir.
Yeah.
If the patient has bilateral extensive rhonchi instead of rolls, the same scenario
With rhonchi.
Patient admitted in ICU with acute breathless. Now, on examination, only bilateral extensive expiratory rhonchi, no rolls. So, what is your? That's the same thing we have right now. We have one case with us. That's why I'm asking.
So this is where in your outpatient setting you look at an NTproBNP that helps you considerably. You have your total count, you're suggesting infection. You have only an NTproBNP being elevated, then you ask for an echo. It's always you need not even ask for an echo. Start treating. You just nebulize your patient, you have your answer.
And rhonchi in heart failure is not unusual. You can have rhonchi in heart failures also. I mean, after all, it is a reactive phenomenon of the bronchi. So if you have some amount of pulmonary congestion, you can have rhonchi in. See, all these so-called within inverted commas undergraduate teachings. I mean, it is good to have a good clinical medicine, everything. The most robust sign in this is a S3, third heart sound. 2 is the tachycardia. See, if you have a unexplained tachycardia, no fever with a third heart sound, I think clinically you are diagnosing heart failure.
Actually, what happened was this patient did not improve with furosemide. It was managed by the doctors. And subsequently, we took a history. He's been having this on and off cold cough every year, seasonal. Then there was a overlapping bronchial asthma was there in addition to S3 cardiac failure.
Yeah,
so that was scenario commonly without that's right.
You are talking about a patient already having cardiac failure with asthma. Is that what you're talking about?
No. New onset.
New onset.
New
okay,
onset
asthma.
Fine. New onset breathless actually.
So I think
not
basically it's the clinician. The clinician is at fault.
Yes.
All you could have done is just tried a nebulizer, which is not going to harm the patient in heart failure. If you had shown total disappearance of the bronchi, you have your diagnosis there. Seasonal asthma, yes, fine. I think it's basically as a professor of medicine, I think he's going into clinical medicine. I think it's perfectly fine. There's no substitute to that, sir.
So the echo is very important apart from proBNP. And of course, we did all these things. And these are the results. ECG shows a left bundle branch block as it is expected. Sometimes you get a left ventricular with strain, X-ray pulmonary congestion. The important thing is the echo. Echo shows a dilated left ventricle, ejection fraction of 35% with pulmonary artery pressure of 50 millimeters of mercury, bilateral effusion. And a proBNP which is very, very high, 300 to 3,500. Renal functions normal, HbA1c, uncontrolled diabetes. So this is a standard garden variety heart failure with reduced ejection fraction. So how would you go about treating the patient?
So basically now your diagnosis is clear. We have everything in place. Your NTproBNP is high, you have a cardiac failure, left bundle branch block with cardiac failure. Very simple. So when you have a cardiac failure, how do you start treating the patient? The first thing you always do is, what do you give? First thing? Diuretics. Excellent. I think all of you have heard enough.
Would you admit the patient?
This is an outpatient. It is not mandatory to admit all patients with heart failure. You can start a diuretic, and if the patient responds, that will be the initial response. That symptomatic relief is going to be given by the diuretic. In fact, what I do, I give them a shot of diuretic. In fact, you have this mouth-dissolving diuretic tablets available now with excellent bioavailability. So if you start using that, within 24 hours, he will tell you, sir, you have done something, what I had for 2 months, I've tremendously improved. By the time you get all your other investigations in place, and then you can start introducing the other drugs. The other drugs, I think what I keep telling practically is there are 3 clinical phenotypes in heart failure. One is the congested phenotype, which is what we are saying. Every fellow is going to be congested when he presents to you. Yeah, you can go to the
In fact,
algorithm.
acute heart failure, I always equate it to hypoglycemia. The amount of satisfaction a patient gets when you treat hypoglycemia, the next minute, no, he sees you as God. Same day, if you give IV diuretic, the next minute he improves. The next day he loses 5 kilos. He will think you are God. So it is important that you give diuretic at this point. I think we need to take it further. Apart from diuretic in the intensive care setting, how would you go about it? I mean, you were telling about the phenotypes.
So 3 phenotypes I keep calling practically is, one is the congested phenotype. The congested phenotype needs diuretics. The SGLT2 inhibitors also can help in the diuretics, so you can start SGLT2 inhibitors fairly early. And once they are dry, that is when you generally start the beta blockers. That's very important. The patient is in acute heart failure, don't give the beta blockers, it might worsen. If you have a window and if the blood pressure is reasonably good, you can start the ARNI straight away. We don't talk about starting ACE inhibitors and then shifting to ARNI nowadays. ARNI is available, it has become very cheap. It's available about 15-20 rupees per day you can get ARNI nowadays. So I think it's fairly cheap. I think much cheaper than most of the diabetic drugs. I think sir should agree with me. So I think it should be fairly cheap to start these drugs. MRA, depending on the potassium, I keep starting. But the important point is, within 4 weeks, all drugs should be on board. Within 4 weeks. Because these drugs start showing their effects very early. Try to adjust individually to your patients. The next practical point which I'd like Sundar to highlight would probably, what do you do if the patient has got a brittle blood pressure of about 90 or 100 systolic?
Yeah. See, again,
in the outpatient setting.
In the outpatient setting, see, the problem with most of the patients is they will come to you with a borderline blood pressure, 90, 100. This patient is different, 110, but it's okay. But the moment you give some diuretics, their pressures may drop around 90, 100. So those are the patients where you need to be very careful. Obviously, the first drug of choice in the big 4 will always be SGLT. SGLT should go in first, and then probably I would slightly differ in this, because MRA, I feel, when you have a loop diuretic in, you need to have some amount of MRA so that you combat the potassium. So that is also okay.
I'll also add one more thing to MRA. MRA is the drug that reduces the blood pressure the least among these drugs. Though we keep talking about resistant hypertension, give MRA. In this scenario, MRA reduces the blood pressure the least.
So you can give a MRA on top of SGLT, and parallelly, if you feel that at the time of discharge, it's okay to get a very minuscule dose of a beta blocker, because beta blockers have shown to have the greatest mortality benefit in heart failure. No other drug has shown that amount of mortality benefit like that of a beta blocker. So obviously a very minuscule dose. Which beta blocker? I wouldn't go for a carvedilol with the lowest blood pressure. I would probably go for a bisoprolol with a very, very minimal dose, 1.25, and then follow up the patient, potassium, renal function, diet, lifestyle, call him back after 2 weeks, and then probably think about ARNI in that case. So that would be my approach in a lowish blood pressure, say 90, 100. But what happens in them is, once you do this, once your cardiac output improves, you get a good blood pressure. So sometimes you have to add these drugs in spite of a lowish blood pressure to get a better blood pressure. Don't worry about the BP falling. In fact, you are giving these drugs so that the cardiac output improves, and subsequently his BP improves. So that is what happens. So
the hypotension in heart failure is defined a little differently. You call it as symptomatic hypotension. Asymptomatic 90-60, please don't worry, they're all fine. They will do well, nothing will happen. I have patients walking around with 85 systolic without any problem, taking 100 milligram twice a day of sacubitril valsartan, 10 milligrams of bisoprolol, MRA and SGLT2 inhibitors. I have not changed the dose. I have kept them on the same. They are absolutely stable. Don't worry about the blood pressure. It's not the numeric value, it is symptomatic hypotension that's important. Another important thing in this particular is the BP drops dramatically. The next thing you have to look at, as a cardiologist, I have the privilege of having an echo machine. I will look at the IVC size, scale down the diuretics and stop the diuretics. Patients do not require long-term diuretics. One of the biggest causes for hypotension is overuse of diuretics. And if you're giving these useless drugs like nitrates and other things for these patients, please stop. None of them are required. Any doubts? Anything you want to talk about this?
Wonderful.
Yeah, go ahead.
Wonderful here. I think most of them will be hesitant to start diuretics with hypotension, and that is well addressed here. Now, the other issue is some of these patients who have, because it's been long standing for 2 months, they may present with some degree of AKI at presentation, so cardiorenal syndrome at presentation itself. And therefore, there's always this inertia of, well, should I use ARNI when you have renal failure, a creatinine of 1.4, a potassium that is hovering to 5.1, with the risk of worsening AKI and hyperkalemia with ARNI. So in this situation, just like hypotension, what would be your thought process?
It's a tough area. Obviously, it is going to be tough when somebody presents to you with, say, a GFR of 40 with a cardiorenal syndrome. Obviously, the go-to drug obviously is going to be SGLT to start with. Because above 20, you can boldly start them on SGLT. Maybe minuscule dose of beta blocker again, because beta blockers are not very much contraindicated. You can use a beta blocker and then follow them up and then get the other drugs on board subsequently.
Practical advice to DD's question. DDPA is sitting in a hospital which is which is a tertiary hospital. You get all these complicated, please don't treat in the outpatient, send it to the hospital. Don't do outpatient management of all these sick patients. Yeah. This needs a lot of monitoring. Be a little careful. Everything is going to be brittle. Be careful. Because if you try doing something as an outpatient, don't try to be too heroic also. Be sensible.
I think many of the patients, you don't miss anything by admitting them. So you can hospitalize them a couple of days, monitor them, see how they behave with the drugs. Because it's like ATT. How they behave with the drugs. Maybe a couple of days, give them counseling and then discharge them.
Yes, Aditya, you wanted to say something?
Sir, my question is very basic and this thing. Regarding in that history, like every time my chief used to say, whenever any heart failure case comes, we should even ask about the erectile dysfunction. I want to know this thing, because any patient who has erectile dysfunction, there is one lesion will be there in the heart, is what my chief used to say. And whenever we used to give the beta blocker also before initiation, that could be better, because always my chief, if I don't write, he used to scold me. That's why I remember. It is a layman doubt. I just want to know the expertise of you, sir.
I'm not sure about it.
Okay, the answer to your question is erectile dysfunction. Basically, you call it as atherosclerosis. Probably when you have atherosclerosis there, you have atherosclerotic disease somewhere else. So possibly that's the simplest explanation I can give you for that.
Beta blocker causing erectile dysfunction.
Beta blocker causing erectile dysfunction. Here, it's going to be very simple. You have a patient who's going to take a beta blocker and survive, or you want a patient who's not having erectile dysfunction and die.
Like that,
no, you need to see.
The choice is yours.
Aditya patient will die of heart, not with erectile dysfunction. Yeah. That can be taken later.
Okay. Most of the patients above the age of 60 with respiratory infection coming to you with resting tachycardia, seeing in the OP. After 3 or 4 days, they come with unusual chest pain. You diagnose atrial fibrillation. So what for these patients with failure you will give?
So atrial fibrillation is a separate disease. If you start looking at atrial fibrillation, first try to find out structurally the heart is normal. If the heart is structurally abnormal, start treating that accordingly. Then you take a fair decision on whether you want a rate control or rhythm control. Depending on the Church-Wasc score, you have to go ahead, anticoagulate the patient and start treating them. That's a separate topic, I think. It's a good question. It happens practically, but I think we should probably have a separate Jugalpandi for that. Sorry, sir. Go ahead.
So this patient, so obviously 4 drugs into the pipeline within 4 weeks. That's the rule. Then diurese, remove the diuretic, loop diuretic as soon as possible once the patient is dry. Then statin, Dr. Narasimhan had already spoken, so we are not going into it. Any role for coronary angiogram? We have 11 minutes. Any role for coronary angiogram? Of course, I mean, you can do if the patient has angina, if the patient has severe heart failure, there is a role for coronary angiogram. What about revascularization? PCI, no. But maybe CABG in a limited set of patients.
See, point is, this is what he's trying to, I'll simplify what he tries to say. The role of a coronary angiogram in a heart failure with reduced ejection fraction has become a little controversial. There's a lot of issues on that, so even if you don't do, because most of the patients with the current medical management, the 4 pillars that we said, see, when you give the 4 pillars, when you treat a patient for 2 years, you save 1 life out of 4. If you just treat 4 patients, you save 1 life. So the mortality reduction is 25%. This is absolute risk reduction.
I think this is the
so when this is there, yeah, this is the lowest NNT. So when you have such treatment, you don't need revascularization. That's the justification for this. It's a little controversial. Beyond that, I don't think we'll fight on that.
Yes, there is a role for ivabradine when your heart rate is above 70 in spite of all the medications. The newer drugs are there, like vericiguat, which is there, which can be added as the fifth pillar if you want to add in refractory cases. I think that is pure cardiology area.
One word of caution at Vericiguat. Please remember, it is not an outpatient drug like digoxin. Vericiguat is reserved for patients who, despite guideline-directed medical therapy, are still symptomatic. So please remember that. It's not a regular drug to be used. Probably leave it to the specialist of heart failure.
I think the older drugs, I mean, very limited benefit, digoxin, hydralazine. I mean, once the big 5 have come, big 4 plus 1 have come, I think we are getting away with the older drug. Device therapies in a limited set of patients does help, like ICD, CRTs and other things. Role of anemia, sir, your favorite topic?
See, I think most of the patients, whenever you have a hemoglobin, even at 11 or 12, if they continue to be symptomatic, you have given a good guideline-directed medical therapy, he continues to have a breathlessness. Look at serum ferritin levels and TSAT. If the ferritin level is less than 100 in these patients, you give them 1 gram of ferric carboxymaltose, 1 gram IV can be given. Or if your ferritin is 100 to 300, again TSAT is less than 20, look at both, again you give them iron. You will find tremendous improvement in symptoms. This iron binding and the capacity of iron to carry oxygen, that's very, very important. I use it extensively. Please do it. And once you give it, it lasts for about 3 to 6 months. The reason why you have to give parenteral iron is oral iron is not absorbed in these patients. So you have to go for a parenteral iron. That's very important and very practical. The other point, now that he said anemia, always vaccinate all your patients with heart failure. Annual dose of flu and pneumococcal vaccine, depending on the age. I will not go too much into that.
So this is the first case. I think we'll go to the next one. So one word is what HbA1c is. These are drugs which he is getting: bisoprolol, DAPA, arni, eplerenone, and torsemide at the end of 1 month.
Will you be satisfied with that, Aditya? I'll ask you this question. Are you happy with this? No.
You are not happy.
What are you not happy?
So why I don't satisfied, because I don't know the eplerenone, how it could be there, and the cost effectiveness. It depends on the cost effectiveness of the patient, and I wanted to know about the anemic status of the patient, because even it says clearly in the guidelines.
All are fine.
All are fine, sir.
Metabolic parameters are fine.
And
Prescription okay. You said it's not okay.
no, sir, because I want to see the torsemide daily for how many days you want to. For 1 month torsemide, I'm never okay, sir. I want
Right,
to.
let's forget it. I'll tell you what I wanted. Okay, your answer is correct, partly correct. Few things. Bisoprolol, you go for a heart rate control. The most important thing is get the heart rate less than 70. Try to get the heart rate as low as 55 to 60 in heart failure. That's the best heart rate. If you're going to use dapagliflozin or empagliflozin, it's pretty much the same dose is fine. Arni, maximum tolerated dose. Try to go up to 200. Don't bother about the hypotension. If you remove the torsemide, you can definitely go up on the dose of Arni. That is fine. Eplerenone, 25 milligram, 50 milligram. What do you do? Okay, now there is a very recent article which has clearly said 25 milligram of spironolactone or 25 milligrams of eplerenone is what has actually been studied. The guidelines have written it wrong and say go up to 50. It is wrong. This is written by Michael Baum. It's a very beautiful article, came about 1 month ago. So you don't have to push the eplerenone. One of the bigger problems of that is the hyperkalemia, which is not going to happen. So this particular patient, get your heart rate down, manage your blood pressure, make sure all 4 drugs are on board. Heart rate is very, very important. That's the only problem with this. We'll go to the next case.
See, what is most important is get all the 4 drugs as early as possible. That is the teaching. That's it. Nothing else. And use NTproBNP just like your HbA1c in diabetes. That's all.
So we'll make this case short. Basically, what we are looking at is a 60-year-old obese lady, and who has presented to you with an occasional nocturnal breathlessness, which is about class 3. I'm not able to do anything. Now, the obese lady, BMI of 38, not able to walk. Classically, most of us see these patients in the outpatient. Old lady coming with breathlessness, you do everything, you do a routine ECG, echo, everything, nothing is showing abnormality. Look at the blood pressure, 180 by 90. So what do you think this patient has? How do you screen these patients? That's the primary question. I'll not go time because we don't have much time.
Obviously, the standard thing what we discussed previously, NTproBNP is important. Obviously, uncontrolled hypertension with suggestion of heart failure. Obviously, you get a renal values, you get your echo done, X-ray, ECG, and all those stuff. So these are the basic things which we have already done. So we'll not go back into that. So these are the investigative results. So patient has a very high BNP again. So that defines heart failure. Then you go to the echo. The only difference between this echo and the previous echo, is your ejection fraction is above 50. The previous echo, the ejection fraction was 35. So you obviously know that this is a heart failure with preserved ejection fraction. Obviously, here there is something important which Dr. Prabhakar will understand, agree with me, that it is not just the ejection fraction. You need to do more. You need to do more about this so-called diastolic function of the heart. So we always look into E by E prime in the mitral Doppler. We always look into the pulmonary vein reversal. We look into the LA strain. All these indices can be looked into in a dedicated echo lab if you have one. Otherwise, I think this gives you the diagnosis, and then you can refer them to either me or Dr. Prabhakar.
He's promoting cardiology, right? I'll just add one more issue in this. So, in a clinic, when you sit and have a patient with breathlessness and a blood pressure is high, you look at the ECG, which is available in most of the places. Left ventricular hypertrophy is a very important thing. So, if you have left ventricular hypertrophy, it means that the heart muscle is thick. There is going to be less compliance. It's like a rubber band. It's not going to stretch. That is what diastolic dysfunction is all about. So left ventricular hypertrophy with the parameters. If any lab is giving you a report of grade 1, grade 2, grade 3 diastolic dysfunction, please change the lab. That's all an outdated, very old formula. It has to be American College of Echocardiography's ACE criteria for a diastolic dysfunction. That is quite different. It is normal, abnormal, intermediate. So that is different. LA strain, he said, is available in very few labs, but if it's there, it's going to be useful because it's the most specific one. Practically speaking, the NTproBNP values I gave you, the 125, 250, 500 for you, for the age, is going to be the best one. But in an acute breathlessness, for the question that DDPA was there, sitting in an ICU, the values are different. Acute breathlessness, patient seen in the emergency department, the rule out is 300. Rule out is 300. But for diagnosis, it is 450, 900, and 1800, same age criteria, 50, 50 to 75, and 75. Now I have a question for the diabetologist. How many of you routinely do NTproBNP to find out a new factor called stress of the heart? Does anybody do? Krishna unfortunately disappeared. Krishna sits here. Normally does that. Krishna is the only fellow who I know who is doing it as a diabetologist. There is a value of NTproBNP of 50. If the value goes more than 50, you think of heart stress in diabetes. It's specifically meant for diabetes. Very few diabetologists, diabetologists don't talk about it. But to make a diagnosis, it is 75, 150, and 300 for the same 3 age criteria. So, and those patients, please get an echocardiography done. This is an outpatient method of doing it. Probably you can go into the management, we can close. Yeah, just 2 minutes.
We'll go. See, what is important in the management of preserved ejection fraction is the controversy, because it's highly controversial. Obviously, you need to, in preserved ejection fraction, it's different from reduced ejection fraction. Here, you need to target the villains which you see. Number one, blood pressure control is going to be the key in this lady. Number two, you need to give diuretics, otherwise the patient is going to go to the next doctor. So you need to symptomatically improve the patient. You need to give some amount of loop diuretics in these patients. These two are standard, getting the risk factors down, getting blood pressure control, diabetes control, everything. But what does evidence say? Do we have any evidence in this area? Obviously, so SGLT.
There are only 2 drugs that have good evidence at this point of time. The SGLT2 inhibitors, yes. ARNI to some extent. If the EF is less than 60%, 50 to 60 probably, ARNI is going to be there in that group of patients. Spironolactone selectively, but finerenone off late of the fine arts is there. I think with that, we will not go too much into the controversy. But I think in an outpatient clinic, NTproBNP is your marker. And if you want to treat, I think all diabetics should be on SGLT2 inhibitors unless they can't tolerate it or some other contraindication. You're going to reduce our practice if you start doing that regularly, which is what is the ultimate goal of 3D-Con. Try to destroy the practice of cardiologists.
That is why there are so many stalls outside, because all diabetics should be on statin, should be on SGLT. So these two are going to be standard. So apart from that, obviously, controversy again, coronary angiogram. So the drugs which are recommended today, which are going to have some amount of mortality benefit, heart failure benefit, are only 2. One is SGLT. Definitely yes, backed up by evidence, both EMPA and DAPA. And the second one is obviously ARNI, controversial, but to a certain extent, at least it reduces blood pressure in this patient, which is important. And of course, finerenone has some data now. So these are some of them. OSA is something which is very, very important. I think most of these obese, short neck women, women with heart failure, with say hypothyroid, I think we are underdiagnosing OSA. Please diagnose OSA, because correcting OSA with a CPAP is going to do a good long way benefit for these patients in the form of symptom benefit for heart failure and also for arrhythmias in the night.
Another last point about these patients with heart failure with preserved ejection fraction. When you treat heart failure with reduced ejection fraction, the NTproBNP levels come down, they don't normalize. But in heart failure with preserved ejection fraction, it actually normalizes. So if you have an elevated NT-proBNP, you treat them adequately with all these drugs, you'll actually notice the NT-proBNP will be normal. Then don't say your original diagnosis was wrong. No, you have treated the patient well. That's all it means. I think we should call it quits.
Being very democratic, the previous patient got DAPA, this patient got EMPA. So torsemide, finerenone.
Both are off patent.
Yeah. And avoid beta blockers. Because in heart failure with preserved ejection fraction, you need to be careful about beta blockers. Because here, the cardiac output is maintained by the heart rate. So you need to have a uppish heart rate. Because otherwise, if you're going to push the heart rate down, the patient is going to become more symptomatic. So try to avoid beta. That is the most important difference between preserved and the reduced ejection fraction. Avoid a beta blocker in this group of patients.
That's a little tricky there. So basically, patient with coronary artery disease with some other indication, please don't withhold the beta blockers. But as an antihypertensive drug and during the treatment, beta blockers are not indicated, because actually when the heart rate is more, the diastolic filling becomes more, the diastolic pressure becomes higher, they become more symptomatic. It's been proven that withdrawal has actually been beneficial. There's a trial called Preserve Heart Failure. Yes, sir.
Excellent, sir. Thank you. I thought I will remember 125 as the cutoff value, because 126 is for diagnosing diabetes.
Beautiful.
Okay. So, but you're saying 50, 75, which one I should?
So, basically it depends on the age of the patient, 50 to 75. So, you remember this 125, double it each time.
But what about this 50 and 75?
That is strain.
50 is, which one?
Strain. Strain. He is talking about the strain.
Diabetic strain.
Diabetic
stress in the diabetes. Oh, that's fine, sir. That's a very new terminology. It is very difficult for you to pick. It's a very new terminology that has come in called heart stress in diabetes. And that is 50 milligrams. Less than 50 is normal. So if you're going to have more than 175, 150 and 300. So for an outpatient practice, for a diabetologist, if you want to do it routinely, you can still do NT-proBNP. It has some value. And if your value is high, please get an echo done. Not the routine echo, get a proper echo done. That's very important.
Thank you.
I think most of these patients benefit with SGLT with a loop diuretic, most of them. SGLT, minimal loop diuretic, most of these patients do well.
Yeah, go ahead, sir.
Really enjoyed this discussion. So when you, regarding this evaporating, when you are using the all pillars for heart failure in sequence, a patient being all right, but persistent tachycardia is there. So the tachycardia indicates is a neuronormal activation heart failure. That indicates a decreased ejection fraction, whatever so. If that is a condition, if you give evaporating to control the heart rate, but it is a reflection of heart failure, you are bringing down the heart rate. Is it okay, or still you go use evaporating?
That's a typical question from Dr. Parandaman. I think all of you will agree with this. This is how he normally thinks. So it's not like that. See, a heart rate is a manifestation. It is a You are not treating the heart failure. You are only treating it. But over a period of time, you give ivabradine only when you can't give the beta blockers. So try to push up the beta blockers. In fact, the other question I would have been happy if you had asked me. I have got the patient on 10 milligram twice a day of ivabradine, or 10 milligrams or 15 milligrams of ivabradine. But the BP is now all right. What should I do? Please change over to beta blocker. You have to come back to beta blockers. That's a better way of looking at it. It's only symptomatic relief. And in fact, in an acute heart failure, when you give ivabradine, you can start beta blocker early actually. Initially bring down the heart rate. It is beneficial. The hemodynamics improve.
Wonderful. Thank you, sir.
Actually, ivabradine, it only acts on the funny current and only in the sinus node. So it is not going to tamper with your sympathetic overactivity, etc., etc. So it is going to only act on the sinus node and reduce the pulse. So giving your diastolic time much improved diastolic time for coronary filling. So that is going to bring down your diastolic pressure, LV-EDP, and that is going to improve your heart failure. So that is how it works. It reduces heart rate, improves diastolic time, improves diastolic filling, and your LV-EDP comes down.
That's more appropriate. Yes, sir. Yes.
Thank you,
Dr.
Sundar and Dr. Prabhakar sir, for the wonderful discussion. Many more take-home messages for us. Thank you for...
Thank you.
Use NT-proBNP more in your clinic. If you want to take one message from the whole thing, use NT-proBNP more in your clinic.
Yeah, that's a great message for all of us. Yeah. And we have a question session for our first talk by Professor Dr. N. Narasimhan. Any questions to Professor Narasimhan, sir? Please be in the microphone.
Sir, I got a question to you, sir. Sir, regarding the newer SI to the armamentariums.
The small interfering RNA are actually in the experimental stage. Some of them had completed the phase 1, some of them completed phase 2 trials. We need to get the information only after phase 3 trials. Till that time, we are totally ignorant.
So, regarding
The future, I'll just tell you something about this. This is something that's coming up, sir. The gene mapping and the genetic changes, there is this double-stranded DNA that can be altered, and once in a lifetime you give this through a carrier vector. It goes, changes the DNA, and there is a permanent treatment for LDLs. This is the future. Small interfering RNA, classical example is inclisiran.
That is available, sir. Inclisiran is available in the market.
Inclisiran is there.
And one thing I would like to appreciate at this forum is, I'm happy you brought up that pneumococcal vaccine as well as the flu vaccine, sir, because heart failure is an immunocompromised state. So people don't think about that. I'm very happy you thought about it, because in many forums I raised up this issue only after saying that then they take it in a half-hearted manner. But you have brought it through you, sir.
I think with regard to the heart failure, you people were discussing about it. And there is a passing mention by Dr. Sundar saying that statin was covered by Dr. Narasimhan. I did not talk anything about the statin role in heart failure. What is your preference of statin? What are the controversies actually behind statin therapy in patients with heart failure?
See, I wouldn't take the controversy. See, obviously, most of the patients who come with a garden variety of heart failure, whatever we discussed, if you want to put it as, I mean, what is the risk category they fall under? They fall under a very high risk category. In fact, most of the patients have some form of atherosclerotic cardiovascular disease underlying. Forget heart failure. And heart failure as a mortality issue, it has higher mortality than the worst of cancers. And most of these patients are going to get hospitalized. At least 50% of them get hospitalized in the first 6 months again. And at least 50% of them are not going to live more than 5 years. So we are talking about the most highest risk category of diabetic patients who develop cardiovascular complications. So I think I would straight away go in for a high intensity statin in most of these patients and try to get the LDL down to less than 50.
So it's two points here. One is heart failure with atherosclerotic cardiovascular disease, without atherosclerotic cardiovascular disease. Without atherosclerotic cardiovascular disease, there is no role for this. Clearly, there is no role. If you want to give for a diabetic, for the diabetes you give, that's fine. But for heart failure per se, there is nothing much. But if you have atherosclerotic cardiovascular disease, go for those. Having said that, you will also notice that heart failure patients have a low level of cholesterol. The reason is because of the cachexia, they have low levels of LDL. That is also known. Per se, statins, heart failure, there's nothing direct. Per se, there's nothing direct. So I don't think there's anything much to talk about. Yeah, so correct. So depending on diabetes, atherosclerotic cardiovascular disease, treat that. But for heart failure itself, there's nothing. Not even antiplatelet agents.
If the patient is a diabetic and if had already been started on statin therapy, he jumps into failure, what will he do at that stage?
Diabetic going into cardiac failure. You're treating the diabetes, I am treating the heart failure.
Thank you, sir. Thank you.